We've used the PEP protocol initiative at our hospital in order to enhance the protein and energy delivery via the enteral route in critically ill patients. Our preliminary results from the 2013 International Nutrition Survey showed that our patients are now receiving 83% of their prescribed energy requirements and 78% of their prescribed protein requirements. 90% of our ventilated patients receive enteral feeding within 24 to 48 hours of admission.
I just can't believe that we've been able to improve that significantly since implementing the PEP protocol. To go from providing about 50% of our protein and energy requirements to our patients right up to that goal target of 80% or more has really gotten me excited about working in the ICU.
We're an 18-bed medical surgical ICU with a surge capacity of 21 beds. It's a closed unit with 4 dedicated intensivists and 1 full-time dietitian. Over the past several years, we've tried several quality improvement initiatives. In 2012, we joined the PEP Collaborative, and in 2013, we've implemented the actual PEP protocol. There were 18 sites across North America that participated in the cluster randomized controlled trial. The main outcome was adequacy of enteral feeding delivery, but also there were no safety concerns reported, and nurses reported that they found the protocol acceptable. It didn't add to their workload.
Here are the main features of the PEP protocol. All patients initially will receive a 100% whey peptide formula. All patients will start on a 100% whey modular supplement, if not on a very high protein formula. All patients will be given metoclopramide, a prokinetic, on day 1 of enteral feeding, and then the nurse can adjust the feeding rate as needed during the day to deliver the daily goal volume. Whey doesn't coagulate when combined with stomach acid, which may promote better feeding tolerance, and that's why a 100% whey peptide formula is part of the Safe Start strategy.
Volume-based feeding is based on a 24-hour volume total rather than an hourly goal rate. The initial infusion rate is determined by dividing the total by 24. The hourly rate may be changed during the day due to interruptions where you have to leave the unit, for example, going for tests, surgery, procedures, and so forth, to achieve that 24-hour volume total. During your daily interprofessional rounds, the nurses will report and include the percentage of feeds that the patient received the previous day.
Let's take a look at the enteral nutrition initiation orders. There are 3 options. The first option is to begin volume-based feeding. The 24-hour period will depend on your ICU. In our ICU, our 24-hour flow sheet day begins at 0700 hours. On day 1, feeds are start at 25 mils per hour. On day 2, the feeding rate is determined by the 24-hour target volume. A dietitian is consulted to calculate the 24-hour target volume, but if a dietitian is not available, you can use a weight-based goal volume that's located on the enteral nutrition initiation orders until the patient is assessed. The hourly rate is then determined using the volume-based feeding schedule, and gastric residual volumes are monitored using the gastric feeding flow chart and the volume-based feeding schedule. Option 2 is to begin trophic feeds, or in our ICU, we like to call them trickle feeds. A 100% whey peptide formula is initiated at 10 mils per hour after the tube placement is confirmed. You don't monitor the gastric residual volume, and you reassess the patient daily for their ability to transition to volume-based feeding. Trophic feeds are intended for those patients who are on vasopressors as long as they're adequately resuscitated, and those patients who aren't suitable for high-volume enteral feeding, like those with ruptured AAA, surgically placed jejunostomy, upper intestinal anastomosis, impending intubation, or risk of refeeding syndrome. Option 3 is NPO, and I like to say just say no to NPO, but there are going to be some exceptions, like those patients with bowel perforation, bowel obstruction, or high-output proximal fistulas. Patients should be reassessed daily, though, to transition to volume-based feeding.
Let's look at a case study using the following PEP bedside tools. You will need to refer to your enteral feeding initiation orders, your volume-based feeding schedule, the gastric residual flow sheet, and the nurse's guideline for management of diarrhea. A 73-year-old male is admitted to your ICU at 2100 hours with a 3-day history of shortness of breath and weakness. Respiratory distress with oxygen saturations of 88% on 15 liters and a respiratory rate of 36 breaths per minute. The patient is now intubated and placed on an FiO2 of 50%, PEP of 15, and a pressure support ventilation of 12. His saturations have now improved and his respiratory rate is settling at 14 breaths per minute. Past medical history is significant for COPD and alcohol dependence. He's admitted to your ICU with a diagnosis of community-acquired pneumonia. He does not have bowel sounds and currently is NPO. The weight is 75 kilograms and the height is 1.8 meters. So what would you anticipate will be ordered for feeding on admission? Will you keep this patient NPO because there are no bowel sounds? Will you initiate the volume-based feeding because he is not receiving any vasopressors? Will you start trophic feeds at the rate per the PEP protocol? Or will you start the metoclopramide and wait for bowel sounds? Many of you would have probably chosen to start the trophic feeds at a rate per the PEP protocol, but the correct answer is to begin the volume-based feeding because he is not receiving any vasopressors and is hemodynamically stable. He was admitted to the ICU for his respiratory status. Will he require protein supplements? Yes, everybody on the PEP protocol will get protein supplements because we want to avoid a nutrition deficit. And remember, this patient was home 3 days, short of breath and very weak. Let's look at the admission orders. The resident orders volume-based feeds for him because he is adequately volume resuscitated and he's not receiving vasopressors. It is now 2200 hours. For day 1 only, feeds will start at 25 mils per hour. So from 2100 hours to the end of your night shift, you will continue feeding this patient at 25 mils per hour. On day 2, your volume-based feeds begin. At 0700 hours, a dietitian still has not yet assessed the patient. So what the nurse will do is recalculate the hourly enteral feeding rate for the next 24 hours based on his weight or until he is reassessed at rounds. So what will the new rate be? Let's take a look at the chart. Follow the patient's weight. He was 75 kilograms on admission. When you look at the 24-hour average, divide his weight by 24, and the correct new rate will be 46 mils per hour.
The patient continues to receive volume-based feeds as per the PEP protocol, but he develops diarrhea and is having 4 to 5 loose stools per day. Which of the following would be an appropriate action? Stopping the tube feeds, stop the metoclopramide, implement the diarrhea management guidelines, or decrease the tube feeding rate? The answer is C, implement the diarrhea management guidelines. All too often, tube feeds are held because of diarrhea, which can significantly impact how well a patient is fed. The diarrhea management guidelines were created to help nursing staff manage diarrhea without holding the tube feeds.
At 8 o'clock in the morning, you measured the gastric residual volume and it is 350 mils. You replace the aspirate and continue feeding at target goal rate. At 12 o'clock, his gastric residuals are measured again and it remains at 350 mils. What will you do? Do you replace the aspirate and decrease the rate by 50 mils per hour? Do you replace all of the aspirate and maintain current feeding rate? Do you replace 300 mils of the aspirate and decrease rate by 25 mils per hour? Or do you not replace aspirate and hold the tube feedings? If you refer to the gastric feeding flow chart, this will help you determine what are the next steps for your patient. The correct answer is replace 300 mils of the aspirate and decrease the rate by 25 mils per hour. On admission day 3, the patient is now receiving 1,500 mils in 24 hours volume-based feeding after the dietitian has reassessed the patient. The feeds were stopped while going for a test and were not started upon return to the unit. At 1,700 hours, the feeds have been off for 4 hours. What rate will you run the feeds for the remainder of the time? We need to use our PEP tools to work through this question. We know that the new daily goal volume is 1,500 mils. So using the volume-based feeding schedule, we can determine that at the beginning of the flow sheet day, the rate was set at 63 mils per hour. We know that the patient received the feeds at a rate of 63 mils per hour until 1,300 hours. Therefore, in this 6-hour period, he received 378 mils of feeding formula. If his daily goal volume is 1,500 mils, and he has received 378 mils already, we subtract to determine that we have 1,122 mils left to infuse. Because the volume-based feeding schedule is in increments of 50, you have to round this up to 1,150 mils. At 1,700 hours, we have 14 hours left in the flow sheet day to provide the rest of the 1,150 mils. So using the volume-based feeding schedule, we see that the new infusion rate would be 82 mils per hour.
The benefits for providing early enteral nutrition and feeding patients at least 80% of their nutrient requirements for the first week of their ICU stay is decreased length of time on the vent, decreased infectious complications, and an overall reduced length of stay in the ICU. The process of creating the PEP protocol and implementing it has really created an atmosphere of collaboration between the dietitian, the nursing staff, and the medical staff. And it has raised the value and priority of nutrition as part of the total medical care for our ICU patients.